We'll talk about approach of SVT in the EP lab. At baseline observations such as initiation, termination, of course septal VA interval, spontaneous PVC or PAC, how does it disturb the tachycardia? The activation in the atrium may give a clue. Presence of pathway potential may be helpful. Cycle length changes, particularly wobble of the tachycardia, would have to be closely looked into. What is fluctuating is the AA interval, the VA interval, or the HA interval, and what is driving the tachycardia. Short RP tachycardia with the R and the P virtually sticking to each other at the tail end of the QRS, with R to P so short, less than 70 milliseconds. Typically with the pseudo R prime in V1 is very suggestive of AV node reentry. Now if you have a close look at the S wave in lead 3, it disappears in sinus rhythm, indicating there was all P wave which disappeared. In terms of long RP tachycardia, R to P interval is longer than the P to R. Generally, atrial tachycardia is the #1 differential diagnosis. Atypical AV node reentry and pathway with long conduction times are unusual causes for long RP tachycardia. When the R to P interval is slightly longer, let's assume the P wave is here, then one can say that this is probably a pathway-mediated tachycardia. It is easy for a pathway to conduct from the ventricle to the atrium due to the impedance mismatch, meaning the ventricle is a high impedance chamber due to the bulk of the muscle, and the atrium is a low impedance chamber. It's easy to conduct from the ventricle to atrium along the pathway, which is why orthodromic reciprocating tachycardia is much more common than antidromic tachycardia, which is in atrium to ventricle on the pathway. Baseline pre-excitation is very helpful in terms of knowing what kind of tachycardia this would be. The location of the tachycardia, we would go through the algorithm that we commonly use, but if V1 is positive, negative, or strongly negative, then you could say it is all left atrial. But here it is somewhat positive, but 2 and 3, much more so 3 is more negative on the pre-excitation, and AVL is also positive, negative, which generally would put you towards the right atrium if it is positive. However, the strong R wave in V1 but early transition along with the inferior negative pre-excitation would suggest it could be posteroseptal mitral annulus, or it could be posteroseptal tricuspid annulus, or even coronary sinus. This is an unusual tachycardia which you should keep in mind. A left bundle, left superior axis, and transition between V4 to V5, very suggestive of Mannheim tachycardia. And you should look for this change in cycle length here. That could be because of retrograde right bundle. Now it has to conduct through the left bundle, which tends to increase the path length and therefore slow down the tachycardia. So here is a summary of short RP. Are we dealing with a short RP tachycardia or long RP tachycardia? Must be determined prior to the procedure. Typically, AV node reentry is the most common for short RP. AT is the most common for long RP, although the alternatives are possible. Now, typically AV node reentry can be long RP in children because of a much more efficient conduction through the fast pathway and returning it back to the atrium rather quickly and beating the QRS. In elderly, it could be the other way around. The QRS is delayed due to infrahisian disease, and therefore the P tends to occur before the QRS, both giving you a pseudo long RP tachycardia even though the patient actually has a short RP, typically re-entry. The QRS duration is 40 milliseconds in duration, or less. You're dealing with anterior interatrial septum, which is the true interatrial septum because it's continuous, whereas anything over 80 milliseconds will be sequential activation of atria, generally posteroseptal location. If you've had prior surgery, or then it's all these timings may not work. Patients on antiarrhythmics, it may not be very effective, and if it's indeterminate, it kind of makes it very challenging to determine where it is. Scar and antiarrhythmics can always muddle the picture. If the R to P duration is less than 70, meaning less than 2 boxes on surface ECGs, favors AV node reentry. R to P duration in a short RP tachycardia, but it is slightly longer than the 70, favors orthodromic reciprocating tachycardia. Now, the atrial tachycardia with long first degree is an unusual cause, but if the P wave is upright in 2-3 AVF, it makes it unlikely that it is due to AV node reentry. It makes it nearly impossible for AV node reentry, and very unlikely even an access pathway. So the pre-excitation, the first 20 milliseconds, 20 to 40 milliseconds is where one looks closely. And the one thing that to remember out of the slide is this area of aortomitral continuity does not have generally accessory pathways. Some case reports are there in the literature, but generally it means you don't get accessory pathway in these locations. Now, if your lead 1 is positive, negative, or completely negative, or V1R greater than S, your left free wall pathway and AVF is positive, then you tend to go left lateral. But if it is negative, you go to the left posterior or left posterolateral pathway. If a lead 2 is sharply negative, it's subepicardial pathway, as in the coronary sinus diverticulum. If you have V1 which is sharply negative or barely isoelectric, then you think of septal. If the AVF is negative, it is posteroseptal tricuspid annulus. If AVF is positive, negative, it could be mitral annulus, in addition to being tricuspid annulus. If your lead 3R is taller than S, is anteroseptal. If your lead 3R is less than the S wave, it's very suggestive of midseptal. If your V1 is positive, it's right free wall pathway. AVF positive puts it right anterolateral. Negative pushes you towards posterolateral. And of course, if lead 2 is positive, it makes it more right lateral. It's very difficult to remember some of every little bit of the criteria, but broadly, if your V1R is positive, you're dealing with a left atrial one, and if your AVF is negative, you're dealing with something posterior. And from there, one can use deductive reasoning to find out where the pathway is located. Obviously, one should understand some of the anatomy for this, and you can see this is the triangle of Koch. This is the extension of the eustachian ridge called the tendon of Toraro. Here's a septal leaflet of the tricuspid annulus and the base formed by the coronary sinus, and the slow pathway is typically around the CS. The more you go towards the roof of the CS, there's a small chance you can hit the AV node. It is better to go towards the floor of the CS, because a compact AV node is somewhere here, and his bundle is located here. Now, the compact AV node can extend all the way up to the roof of the CS. This is why majority of the people would go start the ablation from the tricuspid annulus with ventricular electrogram 4 times out of the atrial electrogram, preferably with some kind of an anisotropic potential, and drag the catheter along towards the floor of the CS. And this would be considered -4, this would be -3, this would be -2, and this would be -1 location where you will hit the compact AV node. Generally, better to start with a larger ventricular electrogram, as the AV node is more of an atrial structure. I think it is better to go around this location. Only if it continues to be inducible, it becomes a problem, then you can go a little higher up. Now, within the AV node, it is within the CS, the initial 2.5 centimeter may host the compact AV node. It is better to avoid location. The same thing is shown in LAO projection. I would spare the first 2.5 centimeters. And if you go, that comes around the 7 o'clock of the mitral annulus, some patients will have left atrial inputs which have to be ablated in this location, particularly patients with AV node reentry. An important point to remember is the fast pathway is somewhat superior to the his bundle recording. It is slightly posterior and slightly leftward. So that's where it is actually break, because it has to break above the tendon of Toraro, and that would be the easiest location for it to go. Fast pathway ablation typically carries about 10 to 20% risk of heart block, as no longer practiced. It was done in the before the advent of the slow pathway, which has a very low risk of complete heart block, less than 1% if you go towards the floor of the CS, and it has become the most common way of ablating in the last 20 years. This is another way of showing the same input. Now, one thing, you would take the patient who has clinical SVT with short RP SVT, and as soon as this happens, you put an atrial extra with barely reduced cycle length. So this may be like 600, 580 or something. And it causes one AH interval and a V, and a second A hiss and V. So sec A hiss. So this is through the fast, this is through the slow, and then a return back up through the fast. So this is what's called a 2-for-1 response, where you have two QRS complexes for one single atrial extra stimulus. There are patients who can have this continuously, called the 2-for-1 tachycardia, and they can mimic atrial fibrillation, and after ablation of the slow pathway, this usually disappears. One thing you would notice that this again goes back through the fast and then eventually terminates. The fast pathway doesn't come back up. That's an unusual thing. Usually the tachycardia terminates in the slow pathway and not in the fast pathway. Usually you will have an A as a return, but unusual things can happen. So this, you can also initiate tachycardia while doing ventricular extra stimulus. And here it is going through the fast pathway because the earliest is his A. And then you have a long AH interval. Typically about 200 milliseconds is the slow pathway part. And the fast pathway occupies negligible portion. So that's why the about 220 or so antegrade and about turnaround and all that may take about 320 to 380 milliseconds is the usual cycle length. And you can see when you have R to P interval is this tight, we say less than 70, but this may be even less than that. then this is very suggestive that the patient you're dealing with re-entry. Sometimes this can happen. You put an extra, you're going through the CS electrogram and the HIS electrogram are competing, which means somewhere else is the breakthrough, and probably a slow pathway breakthrough, and then a long RP tachycardia is started. You can see that the R to P interval is still fairly long. The P to R is very short using the fast pathway, and the R to P is using the slow pathway, the HIS. Typically the CSA is early, but could be the CS catheter. We have not shown the 19 and 20, which would have probably put it here. So a long RP tachycardia, generally atypical AV node re-entry tachycardia, is more often initiated from the ventricle than typical AV node re-entry tachycardia. It's not uncommon that you have some form of an intra-atrial re-entry, and then you start getting the typical AV node re-entry restarted. Non-sustained intra-atrial re-entry is very common, especially as the extra stimulus coming closer and closer to the drivetrain. Usual induction is you will have a jump, such as here. This QRS is from this preceding one. This one makes a jump and then starts the tachycardia. This A is conducting to this HIS, and this is how typically the tachycardia starts. And whenever the PR interval exceeds the RR interval, that itself is a suggestion that you are having a dual AV node physiology, although by definition it has to be a 50 millisecond jump for a millisecond decrement. You also can have a tachycardia start like this, a drivetrain, an extra. A drivetrain is fusing, probably AV node and potentially an accessory pathway. The extra only goes through the pathway. You have a non-sustained bundle branch re-entry, which is fairly common in the lab, and that conducts through the presumptive pathway. And then you have a narrower QRS with a shorter VA interval. And then you have a right bundle branch block with the same VA interval, all suggesting that this patient has a left lateral accessory pathway, a left bundle branch block, and a pacing induced left bundle branch block. Both produce similar VA intervals, whereas the VA is shorter with narrower QRS or right bundle, all suggesting the patient has probably got a left lateral accessory pathway, and the eccentric conduction in the CS would also be in favor of a accessory pathway. It's not uncommon to see a 2-to-1 AV node re-entry, where here's the HIS and here's your V and here's your A, but there's an A but no QRS here, smack in the middle of the 2R to R. Very narrow inverted P wave gives you anterior interatrial septum, and you can generally see a far field HIS because vast majority of 2-to-1 AV node re-entry, in fact greater than 90%, is due to an infrahisian block, and the HIS catheter recording of the potential, HIS potential, is usually reduced because there is no atrial, there's atrial contraction without a ventricular contraction, which moves the catheter in such a way into the ventricle that moves it away from the location where it records very nicely, and tends to get a very far field HIS recording, which is very suggestive that this is an AV node re-entry, especially if the P wave is right in the middle, narrower, negative in lead 3. And usually a PVC or something will happen, which will peel back which will alter the infrahis conduction, and then patient will go one-to-one. So this is a fairly common AV node re-entry with an ultra short RPVA interval. Now whenever a tachycardia is not dependent on the AV node, meaning here's the R to R is suddenly lengthening, but the atrial tachycardia is, or the tachycardia is continuing, it's not, ventricle is not part of the tachycardia. And when the ventricle is not part of the tachycardia, it automatically excludes orthodromic reciprocating tachycardia. And that really narrows it down to an atrial tachycardia or an AV node reentry. An AV node reentry is possible with an infrahisian block, but what you would notice here is the atrial signal and the his are totally disconnected. The AV, it's not at all dependent on the AV node, the tachycardia, and because here is the his signal, and the his signal moves, and the atrial signal there's no correlating AH at all. Even on the conducted beats, you can see that the relationship is constantly changing, which means essentially this is not dependent on the AV node at all, and so this is more likely to be an atrial tachycardia. Now, if you have a high right atrial catheter in the high right atrium, and if the high right atrium is even truly in the high right atrium, not straddling the annulus, and either it is earlier or tied with the HISA and the CSA is later, you should consider at least some form of right-sided accessory pathway needs to be excluded, because it's very difficult to reach a high right atrial catheter quicker than even the annular catheters, unless you think that there's a right-sided accessory path. If you go through the AV node, it's really impossible to reach the high right atrium sooner. You would notice this when you do extras, that the HRA is really beating everything and that indicates if it's truly located in the high right atrium. You can see that this is an atrial catheter because it's barely recording a far field V. That means it's in the appendage or a little higher, which is not at the annular location where the V will be a little. Who had a prior failed ablation, and so it was referred to us, and here we're putting a high density 1-3-1 spacing catheter along the free wall to bracket this so that I can map this area much more closely. The failure to bracket is even in the CS is a possibility, supposing the pathway is almost periappendagish here, and your CS catheter is only up to this. It should be advanced up to this, so you bracket. And because you did not bracket here the eccentric conduction, you can see the ablation catheter is able to produce an A even earlier. If you want to spend a lot of time mapping without bracketing, this is an option, but generally we'll try to advance the CS catheter to get a bracket so that the ablation is quicker. So here is a CS catheter not fully advanced. You can see the eccentric activation in pathway tachycardia, but once we advanced the CS catheter, now you have bracketing. Even very interesting an area, an anisotropic zone where the pathway is probably breaking into the atrium. You can see the V followed by a complex potential, and then you are getting the CS signal LA component. Now, ideal would be to put a PAC and move and see what, move this A out and see what this is made up of. Or you can move the, put a VPD somewhere here and see what components are coming in the A. But I would ordinarily put an atrial extra to move the atrium away to see what component of ventricular electrogram can be seen. Now here is a tachycardia. You can see, always look at the surface. Looks a little bit more upright. HRA is beating everything else, and that alone would tell you the tachycardia is probably an atrial tachycardia. But you can look at this here, 323, and the atrial tachycardia continues to maintain its cycle length. But you can measure the A to H interval here, A to H interval here. The AH is fluctuating, but the tachycardia is totally uninfluenced by any of the thing that's happening. So it shows it's independent from the AV node. It is not dependent on conducting to the ventricle. So that makes it more likely to be an atrial tachycardia. Also, you can see here is we put an extra and the tachycardia starts. And you have the tachycardia cycle length is 441. You have here is the H to A is 158. H to A is 190. This is HA is fluctuating, AH is fluctuating, but the tachycardia ignores all of them. If you have such during the wobble, the one electrogram, the atrial electrogram, is rather fixed, but the HA and the AH are fluctuating. That kind of favors atrial tachycardia. Of course, then the same thing, the A to A is the one that is driving the tachycardia, is very suggestive for dealing with atrial tachycardia. Obviously, if you have a bundle branch which influences the cycle length of the tachycardia, as we see here, the bundle branch tachycardia is wider, slower cycle length, excuse me, and then you have a narrower QRS producing a shorter VA and corresponding reduction in the atrial tachycardia cycle length as participating pathway. This is pretty diagnostic, and you can see a similar situation here. When there is left bundle, it's 290. When there is narrow QRS, it's 236. The bundle branch blocks increase the VA interval and slow the cycle length of the tachycardia, is very suggestive. An ipsilateral accessory pathway. It's fairly easy to understand this. As you go through the AV node, you normally conduct through the bundle and ascend up through the pathway to come form a circuit. But when you go through the right bundle, when the left bundle is blocked, you increase the path length. To get back here, you have to increase the length, and that adds time, and that slows down the tachycardia. It's very diagnostic if this happens. Usually much more common in lateral pathways. In septal pathways, the increase is negligible, between 10 to 15 milliseconds, and it's hard to pick that up. But in free wall pathways, this is much more pronounced. On the other hand, when you have a left lateral pathway and you have a contralateral bundle, right bundle branch block, it doesn't, compared to the narrow QRS, it doesn't do anything to the VA or the tachycardia cycle length. When you have a long RP tachycardia, we consider atrial tachycardia, but here's a very long P wave duration, so it is not anteroseptal. It must be very posterior septal. It is a sequential activation of atrium, not concurrent activation. You can see how wide the P waves are. So this would put me because 2,3 AVF is negative, I would search somewhere away from the septum, or definitely not anteroseptum. I would search for the posteroseptum onwards. I'd start from the coronary sinus and gradually map around 12 noon of the tricuspid at 6 o'clock in the tricuspid annulus, because it's a very posterior, sorry, not 12 noon, 6 p.m. on the, if you have a clock face for the tricuspid valve. So fluoroscopically, this is the site of ablation for this accessory pathway, and that tells you that typically when you have a wider path, wider P waves, you're much, but inferiorly negative, they're more likely to be very posterior. Pre-excited atrial fibrillation, of course, one thing to remember is amiodarone is not the drug of choice, because amiodarone is also acutely a beta blocker. So the drug of choice remains procainamide or ibutylide. Procainamide is manufactured for this purpose. You look at the most pre-excited wave to make where the pathway is, and that way you can understand, because you have a natural selection of some beats being more pre-excited, and some beats are conducted predominantly through the AV node, and some are in between. This is the reason why the posteroseptal area is not contiguous. It has got the coronary sinus, lymphatics, blood vessels, and all that. So the true intraatrial septum is fairly anterior. This is where the P waves tend to be really narrow. The termination gives you some clues as well. There's no A, meaning there's A and a V, but there's no subsequent A. The tachycardia stops when the A doesn't come back. It just makes it much more like an atrial tachycardia, although this is not absolute. Of course, if it repeatedly happens, I would be more in favor. On the other hand, if you have an atrial EGM that does not conduct and therefore tachycardia terminates, I would suspect some form of an AO dependence is there. And within the CS, you can see that here's the CS near field, here's the CS far field. So this pathway is inserted into the CS directly, so-called epicardial pathway, and not the true pathways. Almost all pathways are epicardial, but epicardial by definition is now insertion into the CS. But if your LA signal is ahead of the CS, the far field LA is beating the CS, and the CS occurs after, then I would consider ablation on the endocardial side. But this one, consider searching in the coronary sinus. Now it is easy to see a pathway potential like this. Here's ventricle pathway potential even on the His catheter, and then you have atrial EGM, and of course there is a His in front, so this is not a His, that's the His, and that's a pathway potential. Same thing is recorded on the ablation catheter, and so this would be a good location. Whenever you have a pathway potential, it's possibly the best location to ablate, as the success rates are excellent. In fact, you will see when you have a pathway potential, typically one ablation is all that is required. When you don't have, you just need to ablate quite a bit. And it's always satisfying to see one ablation, less than 10 seconds, disappearance of the pathway. And the recurrence rates are a lot lower if that happens compared to pathway not disappearing. That would suggest that because it fell on the His, there's definitely the presence of a pathway. But if the subsequent AH lengthens, then it becomes very challenging to say whether meaning the His to His never changes. Then you can't say that the pathway is driving the tachycardia. As the PVC is able to pre-excite the A when the His is refractory, that is very, very suggestive that there is a pathway. not very suggestive. It's diagonal. There's no other way you can get to the atrium when the his is already antegradally engaged at exactly the same cycle length as before. So definitely there is a pathway, but if the pathway to participate in the tachycardia, to prove that, the subsequent his would have to be correspondingly pulled in, like here, and that the entire tachycardia from here to the his was 322, then you can say the pathway is participating. On the other hand, this is 355 and this is 355 and this is 355. Yes, the A got pulled, but the A to his lengthened compared to this A to his. That is not diagnostic. It only tells you this could be even be a bystander pathway in a patient with AV node re-entry. So the tachycardia reset by criteria, the his needs to be advanced. If the his is where you start the tachycardia with the PVC, the his needs to be advanced for someone to say the tachycardia. Moving on to the maneuvers part, generally I like PVC on his. I know ventricular overdrive pacing has assumed a lot of importance. You can do the PI or pre-excitation index, PPI, TCL, SAVA. Rarely you may have to put PAC on his if you are, especially for junctional tachycardia versus AV node re-entry. AEST if it is ART. Parahisian pacing will tell you whether it's a pathway. Is the atrium or ventricle necessary for the tachycardia? Here's a PVC on his, exactly the same cycle length. In fact, it's fusing. It's not a full-blown PVC. There's some degree of antigrade wavefront conducted from the his and the PVC colliding, which produces somewhat of a narrowish QS. And the subsequent A, if it is delayed, then that would be just suggestive that there is some degree of pathway-mediated tachycardia is present. On the other hand, if the PVC on his does not advance the tachycardia, then similarly here you can see that here is the tachycardia. Definitely this got pulled in. It fell on the PVC here on the his. But you compare this A to his to this A to his, it accommodated, increased in exactly the same amount. To preserve the tachycardia cycle length, then you have to do the concept of a bystander pathway. So here too, the A to A got pulled in, but the tachycardia, you can see A to his is increased compared to this A to his. So this is very, very suggestive of a bystander pathway. This is the other thing, that the his is pulled in a little bit more compared to this his, but the A is pulled in even more. That would suggest that the patient has an accessible pathway. So this would be diagnostic. PVC on his without approaching the A is terminating the tachycardia, which is very diagnostic that the pathway is participating in tachycardia, and this would be a very, very diagnostic, but it has to happen on a few occasions, not once. Well, one time it could be fortuitous that the PVC and the tachycardia termination occur at the same time, but if it happens repeatedly, it's very, very diagnostic. And here is another PVC on his terminating the tachycardia. In fact, here is the PVC, and the PVC is already, the his is already formed, so the antigrade, and in fact the QRS is fusing here and then terminate tachycardia. On the other hand, if the PVC on his pulls in the A and the tachycardia terminates here, that means there is a pathway present, but it does not tell you whether the pathway is participating in the tachycardia, because the tachycardia terminated the AV node and not at the pathway itself. So here is an interesting ventricular overdrive pacing was started. You can see that this is a fusion, whereas this is much more fully paced, and the tachycardia was ongoing. It fell just before the hiss, less than 40 milliseconds before the hiss is acceptable, because it takes 40 milliseconds to ascend up to the atrium. And you see, this does not conduct to the A and terminates the tachycardia. Even though you're doing VOP or ventricular overdrive pacing, the tachycardia termination here is very diagnostic that this is participating in an accessory mediated tachycardia. So when you have narrow QRS tachycardia, introduce the ventricular premature depolarization during tachycardia, but close to the annulus near earliest atrial potential. If the atrial activation is advanced and atrial activation sequence is unchanged and the tachycardia is reset, meaning the next hiss is pulled in, you have ORT. On the other hand, if the tachycardia is not reset, meaning the next hiss is not pulled in, it could be AV node reentry with a bystander pathway. If your atrial activation sequence is altered, then also you have a totally different thing. So you clearly have a bystander pathway. Now, if your late V2, meaning his refractory V2 is not advanced, you start putting V2 more earlier in the mid-diastolic, and your atrial activation sequence is not advanced, no matter how early you come until you come to the ventricular refractory period, and tachycardia is not reset, you've got atrial tachycardia because it ignores whatever you do to the V. Whereas if your atrial activation sequence is advanced as you come earlier and earlier in diastole, and the sequence is unchanged and the tachycardia does get reset, that means you have to come a lot more premature than the hiss to reset. That means you have to really ascend up to the fast pathway and re-enter the slow pathway. That means it's AV node re-entry, and typically the pre-excitation is the prematurity of the PVC needs to be greater than 100 milliseconds, very suggestive of AV re-entry. So here's one way of calculating 376 minus 36. It pulls in the A at 40 milliseconds, and typically this is the reference paper from the 1980s. Left lateral pathways take typically 75 to 90. That's how premature this has to be. Septal pathways less than 45. Right-sided pathways are less than 40. And AV node re-entry, because it ascends up through the conduction system into the fast pathway. It also collides with the preceding wavefront in the slow pathway, and then it has to really re-enter from the fast pathway back to the slow pathway. So it has to be fairly premature. When you do ventricular overdrive pacing, the most important thing to note is the A really captured? And that is the most critical measurement. And you can see here, compared to here, V to A, it is splaying out. There's no point immediately going and saying it's a VA-AV, or no, this is absolutely not reset the tachycardia. So generally this would exclude the presence of an accessory pathway. So you can see again that the V to A is dissociating, which means and the atrium is independent of the V, and that makes it a pathway mediated tachycardia is excluded this maneuver. Again, is a different way of showing ventricular overdrive pacing with dissociated VNA. On the other hand, when you have a true VA, this is at the paced cycle length, and the first beat to come after that is this, then this is VAAV. That's very diagnostic of an atrial tachycardia. Even though he says early, this is probably somewhere near the anterior tricuspid annulus, or you have to map quite a bit, but this is an atrial tachycardia. And also it's critical to measure the last captured A. This is the most common pitfall everybody falls trap into. So here's a VAAV tachycardia. You're supposed to look at the HIS, VA, HIS V, but this is the last entrained A. So that's the last entrained A, and the HIS is occurring even before or at the same time as the last entrained A. So this is actually a VAV response. So that means this is not an atrial tachycardia. And so the measuring the last captured A is very critical in the diagnosis. Again, if your atrium is not fully captured, there's no point in interpreting the maneuver, and that's what this is. This is trying to trick you into a VAAV versus VAV. And although left lateral pathway can sometimes ignore the right-sided pacing, you could get a VA HIS V response. This rules out a left atrial tachycardia. If this happens, the A was entrained by the ventricular overdrive pacing, you get a VA HIS V response. You also can get this kind of where the A was never entrained. You can see that the V to A is increasing, and then you get this kind of a response immediately. VAV response or VA HIS V response is incorrect. Atrium was never entrained. Sometimes you could truly be entraining the A, but the tachycardia can go like this. But VA HIS V, this could be obviously an AV node re-entry, or this could be a junctional tachycardia. That would depend on additional maneuvers. So the one thing that can happen is to be careful about watching this kind of a response where you pace the V, you get an A, you get no A, you get an A every alternate. I don't think you can use this to interpret this is a VA HIS V response. When you conduct 2 to 1, I agreed this is an eccentric conduction in the atrium, but nevertheless it has to be a 1-to-1 conduction before you can interpret this maneuver. VA HIS V response in a left lateral pathway. Putting APD to pull in, see whether when the HIS refractory APD resets the next A, either pulls in or delays. That is very suggestive of AV node re-entry. On the other hand, if you come in a little bit early and it pulls the immediate HIS, that's very suggestive of junctional tachycardia. If you come in a little early, or even a HIS refractory APD terminates the tachycardia, that would be very suggestive of AV node re-entry. Here is a paper that shows that the S2 is not pulling this HIS, it's pulling the subsequent HIS, which is very suggestive of AV node re-entry. And when you come in very, very early and at 436 milliseconds, it delays the subsequent HIS, or it actually pulls in the next HIS, which is also anything to do with the subsequent HIS has to be more AV node re-entry, not immediate hiss is what is affected by junctional tachycardia. You can do atrial burst pacing, and if the atrial burst pacing is at a shorter cycle length, you can see it's interesting that the high right atrium is captured by this pacing, and yet the stim to CSA is increasing. That means the CSA and the high right atrium are disconnected. It's very unlikely that this will happen in an atrial tachycardia. More likely to be that the QRS and the CSA are ignoring what's happening in the high right atrium, more likely to be AV node re-entry. One way of confirming is VA linking. You can burst pace the A and look at the VA interval. It's 101 first return beat and 101 for the tachycardia from high right atrium. Pacing from distal CS, the return is V to A is 135 and V to A is 93. So when you pace from two different spatial worth reading this, they say delta VA greater than 14. So you can measure this also. The APDs have to be careful in interpretation. If you put it fairly early in diastole, they may be challenging to interpret, but it is better to place them on the HIS catheter than other catheters in interpreting. Which atrium to map in an atrial tachycardia can be judged by burst pacing the left atrium here, and you have a return of 612. You burst pace the right atrium, you get a return of 466. Even for an automatic tachycardia, this suggests that I would map the right atrium then the left atrium, so that you get an idea, even though it is a long RP tachycardia. And the same thing, stim to A minus V to A of less than 85 is also very diagnostic of a pathway mediated tachycardia. So the PPI TCL is fairly useful. This is one of the rough schematics we use. PVC on HIS advances the A, same activation sequence, Tachycardia advanced, ORT. Same activation sequence where the PI is greater than 100 is AV node re-entry, indeterminate. Atrium never captured, HIS advanced not clear. We burst the V, and if you have to VA, AV, it's AT, VAV, rule out AT, and it's indeterminate. Tachycardia breaks without advancing to A. It's AV node re-entry. But V dissociates from A, then you have rule out ORT. Now you can put atrial burst or APD. If there's VA linking, you're dealing with AV, NRT, or ORT. There's no VA linking, you're dealing with atrial tachycardia. The parahisian pacing is equally important. So here it is wider QRS showing 161 milliseconds and narrower QRS, which captures the HIS and the ventricle, is 129. This is an all AV nodal response. This is again a wider, narrower QRS, shorter VA, wider QRS, longer VA. It's very suggestive of all AV nodal response. And same thing is being shown in this slide. And when you have a fixed VA, regardless of whether the QRS is narrow or wide, and it is very fixed, then you're dealing with all accessory pathway. But remember, loss of left bundle capture can pseudo widen the QRS temporarily, but as you come down on the output, the QRS will widen one more time, and then you will have the true ventricular capture. If you're atrial, directly atrial capturing, CS-CGM will be less than 60. In decremental pathways, it's very challenging to interpret this. If your accessory pathway, you should use parahisian for septal pathways, not for pathways in the free wall. Pure Hisian capture can be very narrow QRS, and in fasciculoventricular pathway, we shouldn't be using the maneuver. So here it is a narrower and wider. CS11 is early, 110 milliseconds, very diagnostic of a pathway. So here on the left you see the AV node response post-ablation, narrow cutis showing 140, wider cutis showing 188, but pre-ablation narrow and wide was showing the same interval. You could get direct atrial capture like this, and when you have less than 60 milliseconds, that is very diagnostic of direct atrial capture. When you have a patient with pre-excitation referred for ablation and the QRS shows, regardless of where you pace CS distal and switching to high right atrium, the pre-excitation remains fixed and the stim to pre-excitation is increasing. Suspect vesicular-ventricular pathway, and you can see that whether it's 600 milliseconds or 400 milliseconds, this pre-excitation is beyond the level of the AV node. It's more of a hiss leak into the ventricular, and there has been no tachycardia ever described because of this, and so this should not be ablated. This patient had syncopal spell and was studied at a different institution, and because it was considered too risky to ablate, he was referred to us, and we told him you've got neurocardiogenic syncope, and this has nothing to do with this syncope. Post-ablation, you can also pace the left ventricle. As you can see, the V1 is upright, and now in a left lateral pathway, it is still going through the AV node, and CS12 is late. When you have an antidromic tachycardia or suspected antidromic tachycardia, you put a PAC. Here's a 284 milliseconds. You put a PAC. It pulls in the A, and this is very diagnostic. And then that's very suggestive. This is antidromic tachycardia. On the other hand, a PAC that blocks both in the AV node and the pathway, and then the tachycardia continues, and gradually the pre-excitation resumes. The pathway is bystander here, and this is very, very suggestive of an atrial tachycardia with a bystander pre-excitation. Sometimes it's not uncommon to have VA sequence change, like here. Suddenly the changes occur, and people say there are two pathways. It is actually a mitral annular block created by the ablation, because this ablation was not really targeting the exact location. We ended up producing a mitral annular block. So this is not suggestive of two pathways. And of course, one should consider, here's pacing the A, wider QRS, and then you have the hiss is now visible, and then that's because the pathway blocked. So this is characteristic of Maheim. The stim to pre-excitation may increase before it blocks, and then it comes back up. So this is Maheim needs to be kept in mind whenever you have a left bundle tachycardia with superior axis. It's also worth looking at the near field versus far field. You can see that this is a far field electrogram, somewhat of a near field, but look at the ablation, fractionation with very sharp DP/DT electrogram, and that is the earliest electrogram, and earlier than the surface P. It's reasonable to ablate in that location. The type of junctional beats during AV node re-entry needs to be understood. If you have very rapid junctional, it's better to come off because you're on the compact AV node. Typically, slow pathway ablations are 600 millisecond slow junctionals. And if you have block to the atrium, please come off quickly within a few seconds, preferably within 2 to 3 seconds. That way, the AV node, compact AV node, will not be affected. If you have a change in retrograde activation sequence, then it is very fast, I would come off. If there's any doubt, it is better to come off or pace the atrium a little than the Wenke box cycle length that you had obtained earlier to make sure that you are having ongoing intact AV nodal conduction during ablation. So for the EP, those who are taking EP boards, tachycardia cycle length with lateral bundle branch block, VPD on his advances A and resets, tachycardia VPD on his terminating tachycardia without advancing to the A, post-excitation where the VA lengthens and tachycardia is lengthened, and the bystander pathway are all fair board questions.